Good evening, everyone, and welcome to our September 25th, 2024 Board of Douglas County Commissioners 5:30 business meeting. There are paper copies of the agenda by the door if anyone would like it, and of course the full packet is available on our website. For this evening, we will first have our consent agenda followed by general public comment. We do welcome general public comment for issues addressing items that are not on today's agenda but otherwise related to county business. Given our limited time and the need to have an orderly and efficient meeting, we apply certain rules to public comment. Recent Kansas federal court decision provides some additional clarity regarding standards for public comment. We've updated our practices accordingly. We will do our best to enforce these rules consistently and without regard to the point of view expressed by the speaker. And those are that each speaker gets 3 minutes of speaking time, may not donate unused time to other speakers, and must address topics within the jurisdiction of the County Commission. We also prohibit public comments that are threatening, aggressively hostile, or belligerent, fighting words, slander, or speech that invades the privacy of individuals, unreasonably loud, disruptive, or repetitive, or that interrupt or substantially interfere with the board's ability to conduct county business. We do reserve the right to mute or remove any speaker who violates these public comment rules. At that time, we'd ask for your full name and address for our meeting minutes and to address your comments to the Commission. Please know that comments received by the Commission during our meetings do not necessarily represent the views of Douglas County government, but that we value the input. We don't usually respond to general public comment on the spot, but if you have specific questions, you can leave your information with county staff and we'll try and get those answered. After general public comment, we move to our regular agenda. For this evening, we have one item on our regular agenda. And for each item, we'll hear from staff or an applicant, and then questions from the Commission, and then open that up also for public comment that's relevant to that item. Once public comment is closed, we bring that item back to the Commission for further discussion and a vote. Lastly, a recording of this meeting will be available on the county's YouTube page and website. So with that, we do have a consent agenda. We have 3 items on our consent agenda. And first I'll ask commissioners, do you have any items you would like to pull for further discussion?
No.
Okay. I may have a question on 1.2, so I'll pull that one. Is there anyone in the room who would like to pull an item for further discussion? Seeing none. Jill, can I have you check online to see if we have any hands raised of anyone who'd like to pull a consent agenda item for discussion? We do not. Okay. With that, I would entertain a motion for 1.1 and 1.3.
Motion to approve consent agenda items 1.1 and 1.3.
Second.
All in favor?
Aye.
Aye.
Okay, this passes. For 1.2, we have an item from Public Works. I appreciate Chad being here. This was a resolution about weight limits for certain bridges, and it sounds like some of those bridges that we've had weight limits on, we've replaced those and it no longer applies. Are others then coming on to the rolls for that?
We don't add them very often. This list is shrinking over time. Typically, it's the original design of the bridge is what leads to the limits, and not necessarily like deterioration. So really old bridges, you could see that, but we're kind of through with those. So we should see this list continue to shrink.
And about how many do we have on the list at the moment?
19.
19. All right. Thank you. Commissioners, do you have any other questions? All right. Okay, I appreciate that. I've now open this to public comment. Is there anyone who'd like to make public comment on item 1.2? Jill, do we have anyone online? Okay, thank you. Commissioners, I would entertain a motion there.
Commissioner Reed moved to approve consent agenda item 1.2.
Second.
All in favor?
Aye.
Aye. Motion passes. Thank you. Now we have general public comment. Is there anyone in the room who would like to give general public comment today? And you can come on up.
Commissioners, real quickly, I don't have the time cards to show, so I'll just be doing hand signals, 3 minutes, 2 minutes, 1 minute.
All right, thank you. I appreciate it. Yeah.
My name is Dr. Justin Spees. Karen, I saw on Monday there was an article on LJ World that you participated in Constitution Day down there at the Law Enforcement Center there, and where you read the Constitution. And I have some questions for you about that. First question is, do you feel like a hypocrite standing up there participating in that event? And what I mean by that is that there's been multiple instances of you violating my rights to free speech and equal protection right here in this room. For example, you have stopped me from speaking because You said that I was engaged in personal attacks, a violation of my free speech, because then you also allowed somebody in that meeting to come in and talk about how much they appreciate you and your stoicism and the ability that you listen to people, but then I come in and I say something negative and you shut it down. You also did that on May 1st. I came in with a sign and I started speaking and you immediately shut me down because of, you specifically, you said we're not going to allow the sign while you've allowed other signs in here as well. So another question for you is, since you're so keen on the Constitution that you'll go and virtue signal by reading it, can you explain what the Equal Protection Clause of the 14th Amendment is and how you have or have not violated it by allowing signs in here for some people, but saying that I can't have a sign in here? You allow someone to say nice things about you, but I say something that maybe is critical and I can't speak. You've also shut me down because I came up here and I didn't speak fast enough. I didn't start speaking fast enough, so I lost my right to speak. You shut off the microphone because I didn't speak fast enough. And then, of course, you had me unlawfully arrested on May 1st because of that sign, specifically because of the sign, what it said. And that sign said, women have more balls than Patrick too. And so you had me unlawfully arrested, and that's a violation of First, Fourth, and 14th Amendment. So if you could just take some time to explain what those amendments are and how you actually protect those amendments while you violate my rights. Would you like it if you came in here and you were redressing your government and you got fucking arrested for it, Karen? Do you know the reputational damage that causes? Do you know the financial damage that causes? Would you like that? Because my sign was something that you didn't approve of? So spare me while you sit there and virtue signal the community reading the Constitution while you violate it for me, specifically me, and the words
It's time.
that I say.
Anyone else who'd like to give general public comment?
So as you guys are all aware, my participation in your meeting began when you started screwing with him and arresting him. I believe it was the arrest when Jay Armbruster tossed the sign and created more of a risk with the sign that he threw of his. You guys created allies here. Justin and I weren't on the same side of a lot of things, but you guys created that. I want to thank you for that because it's been a powerful pair that we are, and we're getting some things done. One of the things that we've gotten done here is Karen Willie can actually sit through 3 minutes of public comment without getting in a tizzy and telling somebody they can't talk. That is a marked improvement, Karen. I want to appreciate you for that. But going along with what Justin said about the Constitution, I'd like to know if you can name the 5 elements of the First Amendment. That's an easy one. And that's one that you regularly just play nilly-willy with in here. But as you guys are aware, we haven't been here for the last couple weeks. Part of that has to do with the fact that you're able to sit there for 3 fucking minutes and let us talk without shutting us down. Okay? Maybe what needs to happen now is instead of y'all running to the media and talking about how horrible public discourse is, maybe you teach fucking Bart Littlejohn how to sit for 3 minutes and not talk while people speak. Because that's where the escalation happened in these rooms, was you guys illegally throwing people out, illegally arresting people. When he talks about the personal and reputational cost, the spin that you guys throw in the media, it's a reputational cost. It is, regardless of what people say, but the spin is out there. And you guys do that regularly. But now that you can sit for 3 minutes in this body and not interrupt, let's get the city on the same page and maybe we can chill things out a little bit. What do you say?
Is there anyone else who'd like to give general public comment? Do we have anyone online? All right, thank you. That will close general public comment and bring it back to our one agenda item. And that is that we are going to hear from some of our LDCFM staff about the mobile integrated health. So Jill, do you have an update to begin, or will we go straight to Chief Llewellyn?
Oh, we'll go straight to Chief. You have some background information in the cover memo, but I'm happy to hand it off to the Chief and the team he's brought with him.
Thank you. Come on up.
All right. What do I need to do to share here, Jill?
Hold that up.
Perfect.
You want to do the little, there, the little display function. There you go.
All right, thank you. All right, good evening, Commissioners. I'm Rich Llewellyn, Fire Chief for Lawrence Douglas County Fire Medical. Excited to appear before you tonight to provide an update on our mobile integrated health program. I have some people with me also to speak. To my right is former Division Chief of EMS, Kevin Joels, who's moved on to a different position, a different agency. But since he was critical to the founding of this program and really brought it out and brought it forward, we invited him back to speak in his former capacity, if you will. And it's nicely dressed up tonight for us. And we also have our two mobile integrated health employees. We have Courtney Simonovitz and Kim Barr, and they're all here to share their successes and challenges that they've seen over the last approximately 10 months that the program has been up. So with that, I'll hand this over to Chief Joels.
Just like Chief said, thanks for letting me come back. I appreciate it. As you all know, this was a long process to get to. Commissioner Kelly, you challenged us as an organization to do outside of the box thinking and come up with programs that we were able to do that. And I believe that this is one of them. So at the end, if you want to challenge us again, you can do that.
Say that because you're not here anymore.
100%, 100%. But I will back this program whether I'm here or not. So as we know, but for the people that are listening, mobile integrated health essentially is what it says here on the screen, but it essentially brings right size, right care to the person wherever they live or they reside, whether they're walking on the street or they live on the street, whether they have a home or they live in an apartment. It doesn't really matter who these patients are. It right sizes the care that's being delivered with their non-acute, mostly non-acute needs. So like we said, with us, we have Kim and Courtney, who are two paramedics for the Mobile Integrated Health Program. They are who make up the program. System integration is being worked through. We spent many a month with the Government Performance Lab through the Harvard Business School. Is that who it was? Kennedy School of Business. And we learned that there's opportunities that they can be dispatched through the Emergency Communication Center. That's not happening yet, but there's opportunities to have them integrated into the system, which would prevent ambulances and fire trucks going to these non-acute emergencies or non-acute calls. They work 40 hours a week. They typically work on Mondays, Tuesdays, Thursdays, and Friday. That way that there's never 2 days consecutively that they're not being able to be reached. And it's strategic that way, as opposed to having them. It's important that they work the 40-hour weeks, but it's important that they are working 10-hour shifts so that they have time to decide how their day is going to look, and then they have time to do some paperwork at the end of the day or prepare for the next day. So that's why they're on the 40 hours a week. They do collaborate with the homeless response team quite often. There's a lot of duplication there, and when we presented this program at the beginning, before it had even started, we had said we wanted to prevent as much duplication as possible, and they have done that, but we're still going to see a lot of the same patients. And so seeing them together not only gives them the opportunity to see the homeless response team and let them connect the resources that they have, but then get the medical response team from the Mobile Integrated Health Program. Program activity over the last roughly 10 months. They started in December of 2023. It took about a month to get things up and running. They met with our crews, met with a lot of community partners that they've developed a really good relationship over the months. And then in January, we launched the program. They've collaborated with other MIH programs. There's not that many in the state of Kansas, but they've collaborated with the City of Olathe Fire Department, Kansas City, Kansas, Central Jackson County, which is Blue Springs, Missouri, and several others. They've created training opportunities, or they've attended training opportunities so that they can learn more about their craft. Courtney was the first one that started the fall reduction program, and she's developing that program to do exactly what it says, reduce the amount of calls that we're running, specifically on the falls. Medication delivery in the field, the way that's written is a little bit twofold. There's anticipation to be able to physically deliver as a procedure medications in the field with the right collaboration with direct medical oversight. And then there's also actually going to a pharmacy, picking up medications and bringing them back to the patient who may have difficulty getting that taken care of. And instead of them making them have to navigate public transit or difficult, which is sometimes difficult, they'll actually go get those medications, bring them back to the patient, which is a great option for particular patients. Out of clinic and hospital care coordination, they've developed a lot of relationships, not only with the hospital, Heartland, what am I saying? Community Health Center, sorry, it's so many acronyms. Heartland Community Health, and then also Douglas County Public Health, in which they've collaborated with them recently. I think you all know about it, as they're trying to develop the nurse practitioner program and embed that with mobile integrated health, as well as some of the homeless response. And then assistance to establish primary care provider relationships. Some of these patients have never really been able to get really good care. And so in order to do that, they need somebody to help hold their hand a little bit through that. And so these ladies will assist that and actually sit in a hospital, not in a hospital, in a clinic with the patient and the physician or the nurse practitioner or whoever's delivering that care to make sure that they are understanding exactly what they can get out of that visit, as opposed to never going to the doctor, staying on top of their appointments and things like that. High utilizers was the reason that we developed this program. Every department across the country has them, whether there's many or there's few, they have them. LDCFM and Douglas County is no different. So there's high utilizers, or loyalty customers is what I've referred to them as in the past, but there are the folks that we see a lot, and unnecessarily most of the time it becomes a habit to those patients, and we just need to be able to connect them to resources that make those numerous calls reduce. The fall reduction program was developed in response to 15% of our calls for service in 2023 were 15%. That's quite a bit of calls for one particular call type. And then the unhoused individuals, we know that is prevalent here in the area, and so we want to be able to make sure that they're able to deliver some care in the field to the unhoused that would typically probably end up getting worse before it got better on its own. Some things will go away, like the common cold, but when you've got injuries or wounds that will not heal on their own, these ladies have learned how to do that, and they've had some special training in order to do that. Some of the roadblocks and detours, to be quite honest, these are things that are overcomable, in my opinion. The unpredictable caseload can always be overcome with more staff. And I know that's not, I don't know that I'm here for an ask for that today, but I think that they should have the appropriate amount of staff. But unpredictable caseload means that they could go weeks, I don't think it goes weeks, but they could go weeks without anybody giving them a referral to see a patient, but they're still going to have those ongoing patients that they see often. So the unpredictable caseload is just going to be how busy they are from day to day, and they determine who they can see and who they can push off for another day or however long it can be. They can be put off, I guess. I hate to use that as the right word, but triage those patients is essentially what they have to do each day. The time commitment of an individual patient contact, typically in the emergency services side of things, is maybe minutes on scene, maybe 15 minutes or 20 minutes evaluating a patient and then transporting them to the hospital. But your overall time is probably less than 30 to 45 minutes with a patient. They could spend 1 to 2 hours with a patient just trying to navigate what those patients need. And so in an 8 or a 10-hour day, they could maybe only see 4 patients, and all the while engine 1 and medic 1 will see 10 patients. It just depends on their call volume. High referral volume, we talked a little bit about it with recently in the county chiefs meetings. They've developed, since I've been gone, in just the quick few minutes that I've been gone, a program, and I don't necessarily know that this is a little bit of a pilot program, but the ability for the Douglas County first responders to scan this, that will take them to the to the referral form as opposed to logging back into a computer if a Douglas County first responder is not going back to their station to do a report, but they may be able to do it from home, or it gives them the opportunity to do a referral on scene for that patient right there, right then, so that the mobile integrated health team will see that the next day and they can start some resource connection and contact with that patient. Scope of practice limitations is just to what their scope of being a paramedic is. With the collaboration with the Douglas County Public Health Program and the nurse practitioner and some other connections within the county, there's opportunities to increase that limitation, and they'll be able to do more things under the oversight of other medical professionals, higher level of care. And then consistent patient care management software. The program that we have now is anticipated to have a longitudinal care record, but right now it doesn't. So every time they see Kevin Joels, will use me as a patient. If they see me today, tomorrow, the next day, it's 3 different times. And so that means that when they were going to see me the 4th time, but it's a month from now, they have to go into those 3 consecutive times that they saw me today, tomorrow, and the next day, to learn or relearn because of all the patients that they see, just to remind themselves of what exactly has happened in those first 3 visits of their 4. And so this longitudinal record created by the program that we're using now, or the platform, will be able to give them one look. They just have to log into Kevin Joels and they'll be able to see all of the calls together. If that doesn't take place, there's other avenues to do that, but that's becoming a roadblock for them because it takes a lot of time to review all those calls in the recent past. And so I'm going to invite Kim and Courtney to come visit. But the one thing that these 2 ladies have had to do over their time, they served for years on ambulances. And so that's fast medicine, is what we would call fast medicine. They've had to retrain their brain. I don't think they're there yet. I don't think they're there yet. My time with them for the 9 months that were 9 or 10 months that I got to spend with them, when they'd come back after a day, they looked like they got beat up. And they got beat up because they were disappointed in themselves because they didn't think that they made a difference. Making a difference to them in fast medicine is delivering a patient to the hospital so they can get the care, and then hopefully they're discharged or they stay at a hospital. But when they are discharged from the hospital, that they're fixed. They don't get to fix people on demand anymore, and I think that messes with them because they're in fast medicine. They've turned this program into a slow medicine program, but the slow medicine is better than no medicine. And the no medicine that Douglas County residents were getting before has been corrected. So it's an opportunity for them to share some of the stories that they've had, and I invite them to the podium.
I wanted to flag real quick that the referral form that Kevin was talking about, are you talking about the one that goes directly into MyRC?
Correct. Yeah.
Okay, I just want to make sure that is the form that we've created and we've been using for the past couple years to build the case largely for Project Lively. But then it immediately goes into MyRC so that the other partners in that ecosystem can also see what's happening and help coordinate care with the team.
Yeah, and so that program is, I know that Jill's very fond of that program, as am I. There's opportunities to increase that program or take that program and enhance it, and sometimes that costs money. And I know that's, again, like I can talk about money, I can ask for $1 million, but there are opportunities on beyond just the longitudinal record that can collaborate all of the resources in Douglas County together. That would probably be an enhancement from MyRC. And again, MyRC is really Jill's baby, and so I hate to talk about Jill's baby not ever growing up, but sometimes you got to let the baby go. So I think there's some opportunities, and Jill knows about them as well as the ladies do, so they can talk about that in the future.
So we have 3 success stories, but it was really hard to pick 3 because there's a ton of them. We try to make every patient a success story. So this first one, we had an individual, they've been calling 911 14 times prior to our involvement. They were living in an apartment with nothing but a mattress on the floor. There was no furniture, there was nothing in there. And this was an elderly individual that had some mobility issues. So every time they had to go to the restroom, every time they had to get up in the morning, they would utilize 911 to get up, of no fault of their own. We reached out to several different resources within the county. 100 Good Women, we partnered with them. They ended up buying a bed frame. We put it together for them and got that elevated to the point where they could just get out of bed, and they never called for that ever again. So they got what they needed. The second patient that I want to talk about, they made 24 calls to 911 for just behavioral issues, panic attacks, anxiety. We had a total of 5 visits with this individual. We've seen this on the 911 side where, the ER isn't always the best place for a panic attack, and they don't necessarily, and of no fault of the ER, they're just not specialized in that, right? And so we identified that need, went out and outreached this individual, hooked them up with 988, the TRC, and educated them on their medications that they were already prescribed and making sure they were on a regimen. After 5 visits, we didn't have any more calls. They were able to get the resources they needed for that. And then this third success story that we wanted to talk about was a referral from the Burt Nash Hot Team. We were out doing pit count and, early, I think that was in January, and we're networking and
The HOT would be the homeless outreach team, and the PIT count would be the point in time count, right?
Yep. And so we were out doing that, networking with these individuals. We're like, what is Hot Team? We're brand new, right? And so the individual, the Hot Team member was like, oh, I have somebody, I need you to see this person. You got time? I'm like, sure. So we went to this hotel room where this unhoused individual was currently residing, had some pretty significant lymphedema and sores on the lower legs. So just like swelling and some wounds on the legs. And we're like, well, we're used to just taking people to the hospital. So we contacted our medical director. He was like, let's go in for some training at the wound care clinic. And so we received some specialized training for this individual and was able to treat them for, I don't know how many times we treated him, for a couple months. And by the time we ended treatment, his legs were back to normal. So it was really good success story because he was not able to reach his legs on his own. So huge success.
And again, those are just a few, right? We could be here all night talking about a lot of the success, and the ones that they haven't been successful, they're still working on, and it'll be exciting to hear the next time. That is it for our formal part, but we know that you'll have questions. We hope that you do.
Commissioners, I will have questions, but who would like to start?
Commissioner Kelly, first of all, thank you for this and thank you for your work. I appreciate it. I appreciate you thinking outside the box. And Mr. Joels, I guess I call you now. One of my questions was about, and I know this is coming, how much time, have you done any sort of data collection on the amount of time this has saved you on calls? I mean, I heard that sometimes they spend hours on a medical call. Before, that was probably a paramedic there, maybe not for hours, but for an extended period of time, which meant they couldn't be on another call. Have you done any data collection on that, thinking about how much resources this approach is saving us?
Not yet.
Okay.
So with that point in care, or no, sorry, now your point in time, with the longitudinal record, it makes it difficult without just running every single one of those calls. So it's very time consuming to get the data. The data can be mined. We need some help with that, just because these ladies are not specialists in that. Neither am I, really, to say that as well. We do have Matt Cravens with the county that's been helping. There needs to be some connections with Matt and then LDCFM in order for him to get into some of our programming. And so that's really nothing more than just some business agreements, or maybe even already established with the MyRC program. But essentially the answer is no. With pointed questions like that, we could definitely get it. It's just time. And the care delivery has trumped more of the data. We know that we're making a difference. We see those 3 quick snapshots. The difference has been made. We know that you're very data driven, and we respect that. The data this time, we wanted the story to probably be more the leading here, but we're certainly not shy about the data. We know that we had to get it. It's just not been something that's been achievable. And we really wanted to, and I think I know that I said this, when we were able to launch this, I believe in at least 12 to 18 months before you can really measure it. We could measure something in a week, and I get that too, but I really believe that this program needs a little bit of time before if you have pointed questions like that, I think that you need to ask them so that we can prepare that. Not to say that we're not prepared because you didn't ask, but those are the questions that we need a little bit of help developing, because not every mobile integrated health program across the country is the same. If you've seen one, you've seen one. So the answer today is no. I know that's a long answer, no, but we could get it.
Great.
Yeah,
Okay.
I was just going to say, yes, Dr. Cravens is closely aligned with this, not only monitoring this project, especially as it aligns with the work of Project Lively and evaluating the impact of Project Lively, but how does that intersect with the impact of mobile integrated health? And then I think in the future, you'll hear about how this team and this data could potentially come into play with the county's Familiar Faces initiative as well. I know that's something that Bob's keenly aware of. He's listening. But how all this data intersects. I did just want to share just a couple of highlight numbers that Dr. Cravens had prepared, just to give you a snapshot of just by having the team available in the community, what those referrals look like and what the increase was from the volume previous years. So it was 62 in 2022. In 2023, it was 61. And then when you saw this team come online, it's so far, it's 138. So just the sheer fact that they're available and they have a record of success, they're doing remarkable work. And then just real quickly, Dr. Cravens also was able to provide some of the unique individuals that were associated with those referrals. So 2023, it was 43. 2022 was 43. 2023 was 49. 2024, 108. And I think, again, you see in that number that the response to the team, but you also see the interaction, the way that this team is interacting with the unique work teams, whether that's Project Lively, Mobile Integrated Health, and increasingly working, trying to get out with beyond the city of Lawrence and interacting with the rest of the county as well.
And just to add on to the Project Lively, because you didn't mention them, they meet with Project Lively every week. Maybe they'll skip a week if they don't have much to talk about or somebody's not available, but we'd like to thank Dr. Cravens as well for his participation, because he's typically on all those meetings too, and he sits in the back and doesn't say much until it's time to put his math hat on, so we appreciate that.
I believe he also may be online. I don't know if that means he's available for questions, but I know that I met him in the parking lot and we talked to him about the program.
Yeah, we appreciate it, because he's definitely the propeller head of the group, and we appreciate that.
Just staying on the data line there, so even the stories that you brought, you said you have 15 calls prior, and then we had 5 visits with them, and then resolved the issue. How do you collect even that data for the stories? Like, is that, who's keeping track of how many calls there are before this gets triggered?
Yeah, so that's essentially just done manually. Courtney chose to do that on an Excel spreadsheet and do that manually, which is not going to be conducive for very long.
So you made mentions of software that would help look at that, longitudinally. Is that something that is currently available, or is that something that if we were to look at that for the future would be a new purchase?
It would be a new purchase. It would be a new purchase that could be used by multiple agencies other than just LDCFM or Mobile Integrated Health.
And I've been able to take glimpses of what they've looked at, and I think it's a great solution. I just think that, yes, it will take more resources, but it does offer what's been a weakness from MyRC from the very beginning. And our Johnson County friends will say it was never designed to be a closed loop referral system. So the way the referrals work now, it's real just wonky, and it takes a lot of manual effort. So if there's interest to better organize the way these systems communicate with one another, I think that there's plenty of folks that are interested in supporting that.
I think one of the pieces that would help us make a decision moving forward with that would be getting as much data as we can in order to justify that. And to Commissioner Kelly's point about what he was talking about, what time is it saving, but what resources overall. So presumably, I think you drive a van. Is that right? I think I've seen you on the roads with it.
It's an Explorer right now. It was pictured at the beginning there.
Okay.
It's a temporary. A vehicle has been purchased, but it's I guess COVID still creates an issue with getting cars. It's another Explorer.
So just contrasting that with the cost of that vehicle being deployed versus the cost of an ambulance being deployed, especially in the rural area, and the cost of ambulance, as we know, we see in our budget regularly. So some of those pieces, like, first of all, how many calls? Second of all, what resources were going to those calls? So how do we capture and show to the public, like, this is a program that not only meets people's needs, but it also saves money in calls, because the most expensive vehicle we can send is a fire truck or an ambulance, or both. So that's a piece that really helps us tell the story in the community, as well as the stories of how people are helped with it, but it helps us at budget time.
We understand that.
So you mentioned at the beginning that a possibility that other programs do is to dispatch, just like EMS, but dispatch mobile integrated health to calls. Those probably wouldn't be falls. You'd still want the larger response for that. Like, what calls would come out that would be a better fit for this response as opposed to a larger medical response?
Well, it can come in as a fall, but the interrogation by the dispatchers, the communication specialists would dissect those, and they'd ask a certain set of questions that may realize that they had fallen yesterday, the day before that. They could look back into that longitudinal record at the premise, on the premise notes, to find out if this is a recurring theme. They can ask the questions, are you injured? And if they're having a conversation with them, which is how that would have to go, it'd be a little bit different. Right now, they're working off emergency medical dispatch call notes or cards. And so every question that they ask them takes them to the next question. So they hit a button and it brings up the next question. It's very mechanical. This would probably be the same thing, but it would be a different set of questions, and it would lead them down to say, this sounds like it would be more of a mobile integrated health call. And Chief, if you got more to.
Yeah, I'd just like to pause to see if Courtney has some insight on data
Oh, on data. Well,
or numbers.
Whatever you'd like to say.
I don't know what kind of numbers you want, though.
So I think I'm still stuck on this, like, what kind of call gets dispatched? Is it dispatching mobile integrated health and for the lift assist? Because it's typically not a two-person response, it's usually a four-person
Yeah,
response.
if you've got something to say.
There's, like, we had one individual that was calling because they needed their cell phone charger plugged in. That is obviously not a 911 response, and that's something that we can go to and then figure out what do you need to be able to be self-sufficient? And that's where we would come in. So not a true medical emergency.
So like in the case of that lift assist, is that what's getting dispatched?
Well, right now, nothing's being dispatched that way. It's just referrals. That still needs to be worked out with the communications center on how that's going to look. There's going to be a little bit of trial by fire, I think, on that. We just don't know yet. There's a million things that they could be dispatched to, but with the correct interrogation on the dispatch side, it'll reduce the call for an ambulance or a heavy vehicle. Right now, we're sending a fire truck and not an ambulance to lift assist, which is appropriate because of the number of people. It may be a medic unit and mobile integrated health as opposed to a fire truck, just because there's still 4 people, but yet it's 2 smaller vehicles to go. It's just too early to tell. I think that we're a couple months away from probably that making its debut. But there'll be definitely, I mean, we've talked about it quite a bit, but it just hasn't come to fruition yet.
I'll switch tactics or switch to a different topic. And it's probably for Courtney and Kim. So when you're working with an individual, how much of the rest of their care team and community gets pulled into that? Are you able to talk with family, friends, neighbors that could maybe be part of that self-sufficiency in the future?
If they have it, first and foremost, and if they are willing to, talk to family and friends. And if not, then we can partner, we can try to see, do you need visiting nurses to come into the home? Do you need to be on a waiver to allow, your insurance, if they have the right insurance, to have in-home resources? Like, there's different routes we go down, but we try to get them paired with something if they don't have in-home resources already.
So I'm thinking in terms of kind of my own experiences in elder care and such, sometimes having that as the family member, having an outside professional voice that says, yeah, this isn't working, or we need to, here are other resources, or here are other ways that could make this a lot more self-sufficient for you. Those outside voices are really valuable and helpful. Do you find that family is, I know every case is gonna be different, but do you find that family is wanting to be pulled into that and use that as a resource?
Yeah, for the most part, yeah.
Thank you all for being here. I've been really excited about this program and to hear an update, and I'm glad to hear that it feels like there's real positive momentum and that partnerships seem to be going well. Um, you all mentioned the newish QR codes for first responders to be able to take them straight to that referral form link. Is that being utilized by law enforcement also, for example? Is it also something that first responders in the volunteer fire departments, or are we talking about just LDCFM?
It's new, so it hasn't been utilized yet. We've shared it with all of our partners, but I think with this new tactic, we'll share it with everybody again, because I do think that there are some limitations that some outside agents, well, not outside, but Douglas County agencies have that we don't have. They don't have computers on their trucks, or if you respond in a personal vehicle, you don't have that opportunity to do that. So we'll make sure that it's a pilot program, that we're listening to them. But I guess it's too new, but
Sure.
I was happy to see something different, that it's somebody thinking about something new for them to be able to have those achievements. Speaking on that particular, I do have a little bit of data that was handed. Just to talk about some of the cities outside of Lawrence, looks like there was one utilization from Baldwin, 5 from Eudora, 200 from the city of Lawrence, and then 1 from Lecompton, which creates 287 unique visits. And then I had something else. Oh, 91, I'm sorry, 91 unique patients, but 287 visits over the 9 months.
And I'm sorry, you mentioned the cities, but I know of at least 2 that have been, we used the form and added people into the program from the rural area, and I know that they've had a response. So are you counting those also?
They should be counted unless maybe they were. It could have been it could have been a different agency that. Yeah, these are just the patients that they saw. So what happens there is if they meet about that patient every single week on Mondays at 2:00 in the afternoon, I believe they moved it to. So it's decided on who's going to see that patient. So it's not always mobile integrated health, because you do the community outreach referral form of the CORF. Just because you recommend them doesn't mean that it's going to be mobile integrated health. So that's a good, I guess, I didn't think about that.
Yeah,
But
that makes a lot of
Project Lively could go
sense.
see, yeah.
So I guess one of my thoughts about the data would be, so if someone lives on a rural address, lives in the rural area but has like a Lawrence address, are they being counted as Lawrence? Because I think some of the needs that will start to come to the forefront will be different for folks in rural areas in terms of, transportation to food and medical care and things like that, as opposed to just counting it as, well, their address is Lawrence, but they live 6 miles from town.
I think that's easily dissected out of the data with Esri stuff.
So, thanks for your response. I shouldn't have focused too much on the QR code. What I really meant to ask is, are you getting referrals from other types of first responders, not just paramedics? So are law enforcement sometimes by way of their contact, or I know that there's been some examples shared about working with the HOT team and other sort of crisis response teams in the community. Do you receive referrals directly from them, or do you tend to just interact with them because you realize that that individual is being served by more than one team?
It doesn't sound like we've received any referrals from law enforcement. That could be because we've not done a great job educating on it, or it means that they're already affiliated with that patient and it kind of happens organically, or they're dispatched. So I would venture to guess that we can obviously upgrade the education portion on that, especially with this new tactic of doing it. This will be a good time to do a new program launch.
I think that's where the familiar faces work comes into play. And Bob jumped on. There's a couple things that he wanted to just add about how the other teams all work with this. Bob, you want to offer that?
Yeah, good evening, commissioners and everybody. As I sit and hear this, first off, I just wanted to express appreciation to Courtney and Kim and the whole team in this project. When we're sitting in the Familiar Faces huddles, when we pull people together on multiple teams together, because we all have contact with an individual in common, but not at the same time, and the tools that we can bring to bear are different. Courtney and Kim and this team have been remarkable at collaborating and integrating. We've seen the value of this team, I mean, from the very beginning. So I just wanted to echo that because I didn't want them to just be talking about the good things they're doing themselves. But the second point I think is really important. It's really two things to keep in mind. Each of these new components to the crisis system, right, which ideally is a system that's available as an extension of emergency response. So emergency response is a 24/7 system. These new components are not available 24/7. In a lot of cases, they're not available 7 days a week. The co-responder team, as it's currently configured, is available 4 days a week. This team is available 40 hours a week, but depending on when there's a call or a referral or a need, it's not available 7 days a week, 24/7. The mobile response team, same thing. So there's going to have to be some additional human work at figuring out how to optimize the overlap so that it's true integration and not duplication. And we have to be, I think, realistic and honest with ourselves, that we're 18 months in. In some cases, the homeless response team went online in April. It's just going to take a while for these teams to figure out, number one, what our existing volume of calls are and how they can be deferred. That was one of the things that the GPL, the Government Performance Lab Technical Assistance from Harvard, has helped us to see. Based on data analysis that we all did together, they believe that we could send an alternative response to 30% of the calls that are currently being received by ECC. But you have to have something online all the time to be able to respond to that. So we are learning, I think, what the system needs in this town based on the situations that we're facing. And I just think it's important to keep those pieces in mind. There's a line and a strategy in the upcoming community health plan, the behavioral health plan, that says we need to explore how to get these alternative responses online and available 7 days a week so that there aren't gaps. That they overlap and they're integrated and they can bring to bear the resources that they have, and make sure that regardless of what happens next, we can walk with folks. And we are seeing some significant anecdotal, but again, significant wins through this Familiar Faces collaboration, that should make us all hopeful. As former Chief Joel was saying, these problems and challenges are solvable. We're several months into this process.
Thank you. And I should have led with how much I like this program, and I hear great things about it from the folks who have been on either end of it, either referring folks that, emergency responders know that the response that they're able to give them in that moment is not the long-term fix. So instead, knowing that there is someone who will come alongside and offer that, whatever that might be. But from the folks that are, receiving that care and getting the attention of like, how do I become more sustainable in my home or in my living situation, whatever that might be. So I think it's highly valuable. But we also have to put numbers to that so that we can, project that into the community. I'm not sure that every piece of our crisis system, this non-acute type care, needs to be 24/7. I'm not, and maybe that's something that we will learn and grow into. But I think the 40 hours a week and managing clients as they come in for a non-acute, I think sounds appropriate at this point. So you'll have to kind of teach us as that goes along. I did want to ask about what is the general wait time for someone to get care or get on the list, and the call or the volume of calls that you're dealing with. And that might be hard to answer if this is truly kind of a team approach that maybe you're not the one responding to it, maybe it's another piece of the system.
Yeah, so when we're caught up, we can triage that. If we're available, we'll just go to the 911 call. The crews will either call our phone or they'll call us on the radio and we'll just go. Sometimes if we hear an address, like a repeated address, we'll just go. Or if it sounds like, this isn't really a lift assist, it's, again, I need my phone picked up off the ground, or, there's something of that nature, we'll just go and we can disregard the crew. That's when we're caught up. Right now, we are a little behind, so we triage, we look at how many times they've been calling, because the higher the call volume, that shows us there's a more immediate need. So when I have somebody who's called 3 times before noon, I'm gonna wanna get out there and see them ASAP. That helps relieve the crews, but that also gets them the appropriate resource they need in a timely manner.
I was just gonna say, so what I think I hear you saying is that oftentimes it's a same day response if possible, or within a few days potentially, is sort of the your version of slow medicine versus the fast immediate response.
That's the goal. But then the even more lower acuity, like they've only called a couple times, sometimes it could be a couple weeks. Just frank, honest right now, just because we're behind. But
One of the things oh, sorry, did you want to jump in?
Sometimes it also depends on, like, we get there and it sounds like we can, maybe in a couple visits, really help this individual exponentially. And then sometimes we peel back so many layers and it's just like, oh my goodness, we need a lot more help than we thought we did for this individual. And sometimes it takes longer than we had anticipated. We can plan out each day all that we want, but sometimes that's not exactly how it goes. So that also is a factor as well.
One of the things I've wondered about the program from the start, and I think maybe we're finding that it integrates with other programs that do other things, was, you've got 2 paramedics going to these calls, but sometimes just from, anecdotally what I've seen, that it may be maybe a carpenter that's needed, like maybe something in the house that needs to be altered or fixed for that a person to be able to function well there. Or, is there ever talk about a paramedic and a social worker, or maybe triggering somebody that comes that is able to address something physically in the house?
Yeah, so the initial side of this was to not duplicate what others can do within the county. And so when we asked for this initially, we wanted a nurse practitioner and a paramedic. We were granted 2 paramedics, and we're very blessed with who we have. However, there's still those opportunities to maybe collaborate with others. There are plenty of, I say this, and there's probably some other agencies out there, but there are probably plenty of social workers that could collaborate with this team. But the main goal of this team was to do medical emergencies, as opposed to the social work side of this. This is still social work medicine, paramedicine. And so to have a person within the team, it was discussed. It was discussed when we hired Kim just before that, whether we were going to go with a social worker, a paramedic, or reach for the stars and go for a nurse practitioner. We finally came to the conclusion that a paramedic was going to be probably more advantageous for the program now, because there are opportunities to collaborate with other social workers that are already employed by the county. So adding another, I won't say who, but essentially one of the members that we work with often is, we have plenty of social workers. So there are opportunities to collaborate with them.
We see the integration with the community health workers that are at Heartland Community Health. We also try to make sure that we're leveraging our partnership with Heartland RADAC, the care coordination staff there. So I think we've just tried to make sure that we've made clear to Courtney and Kim that all these resources are available to you. So exhaust them as much as you can, leverage them as much as you can. And when you run into roadblocks, let Bob or I know. So I think in a way, there are resources available. It's just how well are they coordinating care for one another. But I do think there might be, if we have the right data, then we can maybe tell a story where there is a demand for this team to have its own community health worker, which is kind of a different version of a social worker.
And so just to add to that, and maybe Jill doesn't know this, is both the ladies are enrolled through the KDHE for the community health worker program, and they've started that already. On top of that, Courtney, before Kim's arrival, Courtney participated in a mobile integrated health academy on the Missouri side. It's not recognized here in Kansas, but that doesn't matter. It's still the education that she received, and she completed that. So she should be recognized for that. But yeah, the community health worker is an opportunity for not only some funding, additional funding if the opportunity arises, but that education is important for both these to have. So we wouldn't have to look for somebody elsewhere.
Just have one final question. We'll see what else other people have. I've mostly interacted with the program for folks that are housed and typically seniors, but what's the between housed and unhoused folks that you're serving with the program? Do we have an idea of what that split is?
I don't have a percentage, but we've seen 38 unhoused and 53 housed out of that 91 total. And so what allows us, so we only outreach with HRT on Fridays. And so we're able to see, you'll notice like that's for only doing one day, and we only are really there half a day. We start at 7, end around 1. We're able to see more volume in the unhoused population because they're consolidated in one spot usually. And the social work aspect, all the other resources are paired with us. So we are strictly medical on that aspect. Where our house population, there's a lot more stuff we need to get through, if that makes sense.
Go ahead.
So my question is aimed at what we would do if we didn't have mobile integrated health with the unhoused population who had medical needs.
We would do what we did 11 months ago and go see them in a fire truck and an ambulance.
Right. I'm wanting to make sure that we're clear that, sometimes there's a narrative out there that we are creating services for certain members of our population who are more vulnerable. We were providing these services already in a much more expensive way. Is that a correct?
That's correct.
Thank you.
A much more expensive and not as efficient or effective way for the needs that your department and first responders in this community realized could not be met by that fast medicine model, correct?
Correct.
Thank you, Commissioner.
I don't have any other questions, but I just want to take the opportunity to put a point on my earlier question kind of about whether or not you were receiving sort of the variety of sources you might be receiving referrals for. I just want to be clear that my suggestion was not necessarily that is the right way to go. That's obviously a decision for your team in particular about like how and in what ways do you receive direct referrals that you then follow up on figuring out that system. I was just curious about it in part because you have mentioned sort of duplication and collaboration, and sometimes there's some tension between which are we doing, and it kind of depends on a lot of different circumstances, right? And to Bob's point, the sort of growth rate and maturity level of these new services that are coming online periodically. So I was asking those questions out of curiosity, but just wanted to clarify that I didn't mean to suggest any underlying or give any direction that I think you need to be accepting referrals from any and all first responder or crisis worker. I think that there's wisdom to be had about figuring out what your sort of most efficient entry point is to receive that information, and then you playing the role of that sort of close to acute response, and then figuring out how to network to all those other resources makes a lot of sense to me. So I just wanted to clarify that point, and then also just really appreciate how adaptive this job is, and my understanding of community health and paramedicine, and so I appreciate the point that was made earlier. I'm gonna still call you Chief Jules. That they've had to retrain their brains, which I really appreciate you articulating, and that you were trained in a really specific way as paramedics, Courtney and Kim, to have such an acute, fast response and figure out what the next best thing was in that moment and treat everything as an emergency. But it's a really, it says a lot about you too, I think, to have like the care and patience and desire to retrain your brain and figure out how to respond differently and figure out why that fast medicine response, as you all call it, was not meeting the need, and what is the need that's not getting met, what's the root of the problem that other resources can and should fill, and being a conduit for that is really powerful. So I just appreciate you all being committed to figuring out how to retrain your brains. That's like no joke, and do a different job in a very different way. And I hope that the success stories, that you are sharing them with each other and celebrating them a lot, because anecdotally they matter, and sometimes you don't see a very tangible outcome per se, but especially if sort of the next best thing is to connect them to a resource and then you don't really know what happens from there. I know that as a social worker can be frustrating sometimes to not know that there was a quote unquote fix, but it's still really powerful to be a successful connection point. So thanks for your commitment to that.
Just real quick, in my new position, there's mobile integrated health there as well. And just visiting with them over the last couple of weeks, they've run into more emergencies while they're visiting with a patient than they had anticipated. So their education and their I guess being seasoned in this profession is going to come in handy one day. We just don't know when that's going to be. Hopefully never. I appreciate your apology, but unnecessary because you shined a little light on an opportunity for us to engage law enforcement to share that. And I think that we have to be careful in a way on who is able to do these referrals for the simple fact that this could turn into concierge medicine really quick if somebody's asking. And there's been some opportunities where people have heard about the program and they just want these ladies to come visit because they need some help. And that's not what this is about. The people who will need that help will be calling and it'll happen the right way.
I am very excited to hear that there are more plans for outreach to our rural departments and all of our first responder departments to make sure that everybody has access to this, because that's one of the values for if county dollars are spent on something, it needs to be available everywhere and not just in Lawrence or not just what's primarily served even by LDCFM, even though I know we cover medical first response across the county. So I really appreciate that. And both of my commissioners did a better job articulating this than I did, but when we hear from someone in the community that says, I don't want us to pay for homeless services, this is one of the programs, I know it serves housed and unhoused both, but that I think of when I'm talking about spending money in this place can save us money in ways that we're already doing emergency response. But having a way to pull that data together and tell that story with dollars would be really impactful for our community if we want to keep investing in programs like this, which I think we should keep investing in programs like this, but giving us the tools to be able to message that in the community. And that might be a Dr. Matt Cravens, who's listening online, a question to help us work it to that point. But it's a question that I ask a lot of our services that come forward, and often we say, we don't really know, it's hard for us to get that number. We might need people to just, give it a good try. So it's important. So this is a public, oh, go ahead, Commissioner.
I have some comments, but I'll make them after we take public comment.
This is a public hearing item. Is there anyone in the room first who would like to give public comment on this?
Could I just wrap it up with one more comment on our end?
We can call you right back after public comment if you want. Okay. Well, let me just do, there's no one in the room. And, okay, I'm closing public comment and taking it back to Chief Llewellyn.
Right, thanks. I do appreciate the opportunity to come talk to everyone, and your questions are appreciated because we like to know what we don't know. We like to know what areas folks are curious about the services that we offer. And you asked about 11 months ago, what would we do and the impact to the community, and the work that Kim and Courtney is doing is important because it not only reduces the impact on emergency services, but there's some downstream impacts that are being reduced. Those patients aren't being transported to the hospital. So there's not a bed at the hospital being taken by someone who previously would have been taken. As when I was a paramedic, I didn't do wound care. That wasn't in my scope of practice. I'd put those folks on an ambulance and send them to the hospital, and the hospital did wound care. And by reducing the impact to the hospital, we're not only saving community members time who may need those services at the hospital, but we're saving downstream dollars that would have flowed to the hospital or the hospital would have been looking for. So it is a very holistic approach, I think, to medicine that we're getting into, to emergency medicine, but it is extending beyond emergency medicine. And I do appreciate the partnership that we're seeing, the ability to engage social workers in these programs and bring other resources in that, as a firefighter or a paramedic, when I was practicing in the field, we didn't have access to. And so we didn't have those resources coming. And oftentimes we left somebody at home with a a shaky banister on their stairwell. That comes to mind. That wasn't getting fixed and was the cause of some of their falls, and we didn't have those resources. So I think having not only the community paramedics, but the access that they're developing to other resources is important. And I think it's been great to see this program develop. I'm looking forward to watching it in the future. So thank you.
First of all, I can never resist the opportunity to talk about data culture a little bit. You provided a lot of data here, and that's really helpful. We have quantitative and qualitative data, especially in your last slide, looking at, you know, the number of calls that are reduced already is having an impact on your system. So I really appreciate you bringing that data forward. I think oftentimes we think that we use data either to make an argument for or against, and I actually think that's not the proper use of data. The data allows us to ask more questions. That's really what the data is about. And when we ask more questions and get curious about it, that's what leads to possibly new ideas that we haven't thought of before. So I think former Chief Jules, we're going to call you every name in the book this evening, maybe not that one, but I think this sort of stemmed from some conversations around the data that we collected in Project Lively and created some different questions about how do we serve people differently. So I think I just want to caution us about saying, well, if we have the data, we can make a case this way. I think if we just present data as being the numbers and then go, well, what do we learn from that? What does that tell us one way or another? I think that's the right way to use data, even though oftentimes we use it to say this is valuable or not valuable. I think I really appreciate what you said, Chief Jules, about service has to come first and the medicine has to come first. The data is to get it right, and you have Matt Cravens working with you. We have great people doing this. Courtney, the fact that you're keeping it on an Excel spreadsheet just warms my heart because you're trying to see, like, what are the impacts of the work that we're doing? Does the data tell us a story? And maybe I learned something new from that data. So that's really exciting to hear. Love your commitment to it. Love that both you and Kim are taking the time to expand your skill set so that you can serve more people in more effective ways. This is what we need from all of our public servants, is to think that way, that we can do a whole lot more for people if we give just a little bit more of ourselves for our community. So thank you very much for that. Chief Llewellyn, thank you for taking on a challenge when you came to the community and saying, let's think about doing something differently. When I first ran on the commission, one of the things I'd hear as I knocked on door to door is, why do we send a fire truck and an ambulance to every emergency? I can now say we don't, right? And so thank you. And lastly, I want to thank former Chief Jules for your work with Douglas County. We have interacted with you quite a bit as the commission because we're on the medical side of the fire and medical. Your dedication and willingness to look at things differently, to give us data when we asked for it, to maybe look at it a little differently than we've looked at it before, I have really appreciated. We're very much going to miss you, and thank you for your service to Douglas County.
And also welcome to Chief John Darling, who is stepping into that role, not to be overshadowed by our saying farewell to a long-time partner. One of the things I heard my ride along with LDCFM was that this program was one they looked to that addresses some of the burnout they were feeling, like that going to the same call over and over again and feeling like you're not helping was a real aspect of burnout for some of those crews, especially when those calls were in the middle of the night. So they really looked to this to say, not only are we benefiting somebody's actual quality of life, but we can, focus our energies on the calls that we feel like we're making a dent. So. Any further comments? This is an information-only item, and this is why nobody wants to be our only item on an agenda, because we have asked you a lot of questions and spent a lot of time with it, and it's because we so value the work that you do. So I appreciate your patience and coming to share with us this evening, and we look forward to, as the program evolves, what else we're learning from you and you're learning from us. So commissioners, any other final thoughts for them? Okay, with that, thank you, and that is the end of our regular agenda. And we will move to Jill for our weekly memo.
Commissioners, I don't think I'm not looking at the most recent updated version of the weekly memo, but
We
you've got
can
some,
look at appointments first, then.
Oh,
If
sorry.
anybody wants to do that, that would be my fault.
I don't, did we have any in our inbox for this week?
I have one.
Okay, thank
Yes.
you.
Which is why he was asking.
So yeah, I did have a chance to talk to Dr. Bill DeWitt, and I talked to Mark Pruitt, who is the new principal at the College and Career Center, as overseeing programs there on the campus with Peasley Tech. And I'd like to nominate Mark Pruitt for the K-12 education position to fill that partial term for the Peasley Tech Board.
Second that. All in favor?
Aye.
Thank you. And I do have one in the works and still waiting to hear back from the DA, so I will work on that one again. Any other appointments? Jill, the rest of the memo?
yeah, one of the items that is not on here, but we'll make sure we get that updated is, it's very timely, is October 1st is there's going to be a groundbreaking for Delmar Place, which is one of the new developments that the Lawrence Douglas County Housing Authority is going to be having a groundbreaking on. Commissioner Willie is going to be speaking at that. It's 1:00 on October 1st. And all those details will be on our website and in the commissioner's memo. Another item that I know was in the memo is there's going to be shortly after into mid-November that is not on the memo, and I'll hit the items that are on there, is there's going to be an orientation for new members for the Planning Commission, I believe was one of the items that's on there that's coming up in November. It didn't make it onto the version of the memo that I'm looking at right now, and I apologize. We'll get that updated. Other items that you see on here is there's a behavioral health court graduation that's happening tomorrow. That's at 1:30 in Division 2. You've also got DECA's 50-year celebration tomorrow. KDOT's hosting a groundbreaking also next week on October 2nd. Your judge's quarterly meeting date for the next one is also October 2nd. And you can see where that's at. Then also just continuing to flag that the canvas for the 2024 general election is going to be on the November 18th. Informational items, you've got Board of Commissioners for Lawrence Douglas County Housing Authority, the Public Health Board, minutes that are on there. We added information about the Youth Entrepreneurship Challenge flyer that's there for our annual event, and that date is going to be Friday, February 7th. The flyer's in the packet. We are going to be doing a warm-up webinar for that is going to be on October 18th that will highlight that in next week's manager's memo, but it's a webinar for students that are interested in competing for that. And then next week, looking to next week, we'll have a work session that will be with the Heritage Conservation Council, providing their annual update. And then we don't have any work sessions that are scheduled for the remaining dates that the commission meets in October. And no meeting on October 30th, it's been determined.
Thanks, Jill. I just want to make a quick point of order that we've actually moved the judge's lunch to October 16th, so that just needs to get updated in the memo by next week. It's no big deal. I think we all probably have it on all our calendars, correct?
All right, commissioners, do you have anything else for this evening? All right, with that, we are adjourned. Thank you all.